Every day, people just like you are searching for answers to feel better, live stronger, and finally understand what their bodies are trying to say. Here on PremierU Decoded, we uncover the science behind true wellness, from hormones and metabolism to the daily habits that shape your future. Because beneath every symptom is a message your cells are sending. And when we listen, we transform. I'm Dr. Brandon Williams, and together we're building health, hope, and confidence at the cellular level.
Welcome back to Decoded, the podcast where we take health topics that usually feel overwhelming, confusing, and honestly, maybe a little boring, and decode what they actually mean. Today, we're tackling something that everyone thinks they understand: heart health and cholesterol. Because somewhere along the way, you were all taught that cholesterol is bad. If your labs are normal, you're fine. It's just genetics. Hey, guess what? Spoiler alert, it's not that simple. In this episode, we're decoding cardiovascular health beyond the headline numbers. We're talking about what your lipid panel is really telling you and why your stress and hormones really matter, just as much as your diet, and how you can be proactive about your heart without living in fear and cutting out all the foods that you love. Hey, I'm joined by Brandon, and together we're breaking down the myths and misconceptions and the modern approach to heart health that actually fits your life. Episode 2. Let's start decoding. Hey, Brandon, welcome back.
Thank you. Welcome back.
How'd you feel the first episode?
Good. We had some technical issues, but we're getting those lined out, so it's going to be good. The information's good. That's what I'm excited about.
Yeah. Did you get any feedback from the first one? Anyone reach out? Any burning questions? It was like that aha moment for you?
I think people felt like it was a good introduction to what we do ultimately, and they wanted to hear more. Obviously, they were excited about the future of this and to see it grow.
Yeah. So let's do it. Let's take it down to the next level. And like we said prior to starting to record, this is information we're going to talk about that people thought that they understood, and we might just be busting some of those myths, some brain busters,
I hope so.
say, right? So let's dive in. Let's get them started. No longer have to wait. So let's start here. Why do so many people think cholesterol is the whole story when it comes to heart health?
So this entire topic is very important. I think it's created. I look at things in a framework for education, but also a framework for how we communicate to patients. We as providers, we want to do a good job. We want to take care of people. We also want to be able to communicate to them in a way that they can understand. And this topic is something that is very difficult to do that. It is something that is very complex. It's very nuanced. It's ever evolving because it's so very important. Cardiovascular health is very expensive, and it kills a lot of people. Mm-hmm. It also harms a lot of people. As a result of that, it's become very important to understand this well, figure out how to apply it, to not be confusing, and also to not just have a dogma about how you approach this problem. There's a narrative that I was raised to have, I was trained to have, that has become perpetuated throughout even medicine, which is that things are good or bad. Yeah. And it's too reductive to talk about things as good cholesterol and bad cholesterol. Ultimately, our cholesterol is requirement for life. It has an important job in our body. It transports all kinds of things. It transports energy. It transports hormones. It cleans up end products of things that need to get out of the system that ultimately go back to the liver to be processed, burned, or excreted. So it's not a bad thing. LDL is not a bad guy, just like HDL is not particularly harmful, but it's also not a good guy because it's got some negative aspects as well. And it's more so, my purpose here, what I hope to accomplish today, is to create a better viewpoint of how to approach health, to recognize patterns, to expand the conversation so that people can figure out how to truly impact their health and not say, we all know people that have said, I did all the right things. My labs look fine. Mm-hmm. I'm on the right medicines. I've done what my doctor told me to do. Why did I have a heart attack? This exact percentage will help everybody understand the importance of that. 50% of the people that present to the emergency room with a heart attack have an LDL cholesterol that is normal, that is less than 100. 25% have an LDL cholesterol that is less than 70. That's a big problem because we're told just lower your cholesterol and you'll be fine. That's not the case. Yeah. It is much more nuanced than that. It requires a deeper dive, a better understanding of lipid management, or lipidology is the phrase for that. And there are people who specialize in just that topic because it's so very important. And that's kind of what I hope to demystify a little bit, though it is very complicated. And again, right now as we talk and do this, that information is rolling out. Science is proving new matters, changing the way we think about things. And I think that's what's important. As we as providers, we in healthcare and medicine have to be able to keep up with that. Not just take something that says, well, there was a study in 2022 that showed X, Y, Z. What does science tell us? What does physiology tell us? What is logical? What does statistics actually mean? Which is also very important because research is manipulatable. Mm-hmm. And you have to be able to look through that to make a real assertion about how to impact health in a valid way while not being dangerous, and how to do things that make people's lives better versus just scaring them or leaving them in this nebulous place that doesn't actually lead to something that is a positive health outcome.
Yeah. Well, we know with this audience, we have people listening who are providers, who mm-hmm. are hungry for new information. We also have people who are patients of mm-hmm. ours, or people who are just interested in health. And what I heard you say is there's a piece that's missing in this puzzle, because LDN for a lot of folks is like, well, that's just something that when they run a panel on mm-hmm. me, they run, and then I'm in those, what I like to say is like the goalpost, right? If you're in there, you're golden.
You're fine.
You're golden, right? And they send you on your way. But what I heard you say is like, well, no, you're not golden anymore. Like maybe you never, what I heard you say is that you were never golden, right? Like there was pieces that we were missing. Mm-hmm. So what would you say for people who are listening who said, oh gosh, I never thought about it like that. What is the missing piece? You talked about lipid management. What does that mean? And how does that play as the missing piece in this overall picture of health?
Okay. So this part you'll have to stop me and say, explain this better, break this out, because it's, again, I'm going to use that word again. We try to make things too reductive, and we mm-hmm. just can't do that. Part of it is most providers don't have enough time yes. with their patients. They don't have time for the education either, which is why I think this is important to inform the patient, right? People that aren't our patients, but also that they can help take control of their health, and ultimately to help their doctor, because their doctor, if they're able to spend 10 minutes with you, and half of that is just hearing about why you're there and reviewing things, they don't really have time for education, which is why I appreciate what we do to be able to spend time. It's about looking at the pattern, the overall picture. And I don't like this word holistic because it gets used in various ways, but to look in a whole sense, a whole system. To break out LDL cholesterol, we're going to have to talk about the fine minutiae and details of that. So when you look at lab reports, even a simple lipid panel, when you see a value for LDL cholesterol, what you're seeing is not necessarily the LDL mm-hmm. number. You're seeing the amount of cholesterol that's inside LDL particles. LDL are particles, HDL are particles. There's VLDL, these other forms that are just packets of fuel, packets of hormones, packets of information, molecular signaling. It's an energy exchange molecule that carries things throughout the body. That becomes very important because you think about how much cholesterol is packed inside these, but you also have to know things like how large are these particles. Larger particles tend to be a little bit better. Smaller particles tend to be a little bit more harmful. If you look at things from a plaque perspective, cardiovascular disease, heart attacks and strokes, peripheral vascular disease, things that get into the vessel wall, get in through an injury into the wall, those tend to be smaller particles. They tend to be more pro-inflammatory particles. That last part becomes very important. All of these things need to be considered in what context do they exist. So what is the system like? Is the system healthy, metabolically healthy? Does it have a low inflammatory profile? If the answer is no, then the consequences of that cholesterol, that LDL, those small particles, mm-hmm. is going to be very different than if it's in a healthy person otherwise. It's really interesting, and part of this conversation changed dramatically with the understanding of, it's a different classification of people, but it's sort of rocked the understanding of LDL cholesterol. I'll be in brief because this could take a while, but there are these subset of the population with the change to working out more, anti-inflammatory lifestyles, or just ketogenic diets that made this revelation of people called lean mass hyperresponders. Now, why these people are important are that they have a ketogenic diet, which if you don't know is low carb, high fat, and moderate protein. And there's nuances to that. We won't go off into the keto thing. But just to say, they have often very high LDL cholesterol numbers, but they have low metabolic disease. And there have been studies on those patients, despite them having an LDL cholesterol in the 3, 4, 500 range, of not having plaque progression. And what do I mean by that? So when you look at plaque progression, there's different ways to assess that. 3 main forms. There is, it's an ultrasound study you can do called the carotid intima media thickness to measure how much thickness there is in that vessel wall. Non-invasive study. There's a calcium CT score. It's a non-contrast based CT scan that's very quick. It tells you how much calcium do you have in your coronary vessel. Then there's things like a coronary CT angiogram, which requires dye. It's a much more detailed picture, but it gives you a lot more information. That last one, the most information study, they looked at these lean mass hyperresponders and followed them for 1 to 3 years and noticed that they did not have increasing plaque. They actually had often regression of plaque, which brings up a new tangent to talk about the ability to have plaque regress. And this is known. There is clear molecular pathways that are known, not completely elucidated, but known about how we can take plaque out of vessel walls, put it back into circulation so that it can go to the liver and either be burned or excreted. And that's remarkable. That is not something that I was taught to believe or understand or think could occur, but it does. And there's actually really fairly clear mechanisms for how that works and ways to interact with it specifically. So those things I think are important to understand, that there's this broader picture. And if you go back to it needs to be a low inflammation state. I'm trying to make this clear, but also not to go off on too many tangents because most of these could require their own podcast.
Yeah.
I'll use a different phrase of something called oxidative stress. So that is a big phrase. So if you look in biochemical terms, there's oxidation and then reduction, and our body functions on that. Neither one is good or bad. We like to refer to these terms as good or bad, like oxidative stress sounds like, oh, oxidation's bad. If you don't have oxidation, you're not going to be alive. It's a requirement. And it's actually a nice signaling mechanism. The question is, in what context does it exist? And is it allowed to perpetuate for too long, right? Like your immune system. It works by sensing the environment. If you get sick, if you have a virus or a bacteria, you want your immune system to go all out. And you want those things to migrate and take care of this problem, but you also want them to stop. And when things become uncontrolled and they don't stop, that's autoimmune disease, right? As a simple example. So all of these things that are good also have bad detriments if they're not controlled. It's like the mantra of too much of a good thing, so to speak. And also things that are historically good can become bad if left to be in excess as well. So looking at lab reports, here's what I tend to look at, and I can explain why later. I want to understand their LDL cholesterol number in the context of the grander scheme of what is their apolipoprotein B? What is their LP little a? What are their particle sizes of their LDL, large versus small? What is their PLA2 activity? So that's an inflammatory marker. Looking at something like myeloperoxidase, which is, to use that phrase, oxidative stress, measuring the amount of oxidative stress that that patient has. Understanding their history, understanding if they have a large family history of cardiovascular disease, if they have familial hypercholesterolemia, what has their diet lifestyle been like? And that creates a whole picture of a person. And it's much more complicated than just looking at that one singular lab value and saying that's good or it's bad. Again, we've already talked about how you can have normal or great LDL cholesterol numbers, and still be at risk for cardiovascular disease.
And let's talk about that a little bit, right? Because for people listening, they might be like, oh gosh, I never thought about it like this, because they've received the reassurance, maybe when they're going to their doctor, who has limited time to educate what those lab values really mean. Mm-hmm. Or do their doctors even listen to podcasts or other information to even have them start thinking about these other areas? Because as you said, even in school, you weren't taught in these ways. Mm-hmm. So for them listening to say, oh gosh, I thought I was doing all the right things. Every year I'm going in to get my blood work because my doctor wants me to check my cholesterol. Mm-hmm. I do it. It's been a normal range. So I've checked this off the box that I'm doing well. What I'm hearing on this podcast is that there's something more. Yes. So what would you say to those people who are thinking that of, oh gosh, could this be something more? What questions should they be asking to their doctor, or what, even self-reflection things should they think about in their own lifestyle to make sure that they are doing all the right things and not just reliant on those lab values to say you're good?
Sure. Yeah, and answering that completely is going to take a long time. So I guess to boil that down, to be able to, we get asked this often, like, how do I communicate with my doctor? Or more so, how I look at it and say, does this provider that you see agree with what you want and with what your goals are? If they are not capable of or don't communicate in this way with you, maybe they're not the right person for you. Mm-hmm. You should find, there's plenty of people that are like this. There's plenty of cardiologists, primary cares, wonderful doctors who communicate in this way. They're few and far between. It could be because they don't have time, or it's because they don't have this knowledge, right? Their society, their board didn't tell them this, and therefore they don't know this information because they're not keeping up, or they're not using logic and applying that mm-hmm. to research that comes out, which is a separate problem. I know as somebody who reads a lot of research, it's not easy. I worked in research, but I also know how research can be manipulated. I've seen it live. Yeah. I've seen data be manipulated, or if you don't fully understand the terms that are being used, like if you use the terms causation, absolute versus relative risk reduction, those things mean very different things. And that's very hard for a busy provider to keep up with. And when you've got large organizations and a large front, large movement behind an idea, like use this drug to lower this lab value because that's the best way you can approach this problem. For a lot of people, that might be true. And it's an easy mantra to echo in a busy medical practice. I see this abnormal lab value. I do these things, which includes a statin drug or some other drug. And maybe I say, you need to eat better and move more. That's about the extent of the recommendations. I just had it yesterday from a young individual, just saw his primary care doctor, mildly elevated cholesterol, and the doctor just said, just stop eating eggs. Okay, well, that's not great. That's a whole separate problem about talking about management of dietary intake of cholesterol and how it affects your lipid management, which we won't go off into, but that was the recommendation given. Yeah. And that patient at least knew enough to say, I don't feel good about that. That doesn't make sense to me. It's not what I've seen in the literature.
More.
Yeah, so he appreciated a different kind of conversation. Like, well, let's talk about that. Here's why they say that, right? And let's figure out a better way to manage this problem. The whole idea that we try to reduce things in medicine to make things simplistic, and also, let's be honest, a lot of patients don't want to do the hard work that's necessary to accomplish true, impactful health-related changes. Those patients that do, God love them. And I'll take an entire practice full of those people. And everybody else, I'm going to do my best to help. And I'll try to impact them where I can. To have the pillars of health in place, where you've got a good dietary management scheme that works well for you, considering your goals, that you exercise in the form that fits you best and whatever your goals are, and considering your family history, and that you sleep. And those things sound easy when you reduce it down to just 3 pillars, but they're very nuanced and they're not easy, particularly that sleep part.
Yes.
That's very difficult for people. And then you layer in the complexity for, like, we'll talk about females for a second. Layer in the complexity of, you move to a phase of your life where, I hate to say it this way, but in many circles of medicine, once you're beyond reproductive years, your health and your life no longer matters to them. But they are supposed to be those places of resource, the guiding light for how should I guide my life and how to be safe. And very often that is just missed. Not everywhere. It's not completely pervasive, but it is very common, unfortunately. And this idea of perimenopause and menopause and the changes that happen, to say these things, this loss of hormones, is part of a natural part of aging, so to speak. Mm-hmm. It doesn't mean that it's that's a good thing just because it happens when you age. It doesn't necessarily mean that it's a bad thing that it happens either, but it does need to be managed considering the person that's in front of you. That's a very individual question to answer. Should I use bioidentical hormone replacement? That's what I'll talk about, because I don't like synthetics for different reasons. That requires its own podcast episode. But this idea that you've lost inflammation reduction, you've lost whole body support, you've lost control of these patterns and mechanisms in your biology that lead to biochemical changes that are potentially negative, that are allowing things that were previously not bad to become unregulated. Mm-hmm. And that's a problem. Like, to pick one of those out, estrogen in particular, it's very good at reducing inflammation. It's very good at managing oxidative stress. It's why it's being shown and has been shown to be very protective for the brain and the heart, as well as the muscles and the bones. Mm-hmm. And those mechanisms have to be understood. You have to know how to apply that tool, because if applied inappropriately, could be a bad thing, right? Or if in the wrong system, if you've got somebody who has estrogen receptor positive cancer types, that would be a bad thing, right? If you don't take that into consideration. But there's different ways to treat those patients too. There's different ways to reduce inflammation. That's not like, well, screw it, your life's over.
You're done.
Right, you're done. Sorry, you've got bad receptors in your body. No, there's other options, and that's where it takes somebody who says, okay, I've got 1,000 tools at my helm to treat this problem. Yeah. Which ones of those tools do you agree with, do you want, will fit into your lifestyle, and are going to make a positive impact to your health? And that's where this time and relationship and understanding the patients in the front of you, and also understanding the provider and who's trying their best to communicate with you. And like for me, as somebody who talks too much, I tell people, just interrupt me. If it doesn't make sense, stop me and let me make myself more clear.
All right, let's interrupt.
Let's do it. Thank you.
And there we go.
Yeah, perfect.
I think last year you remember that we brought the M Factor, Tamsin Fidel's documentary here. And for people who haven't seen the documentary, it's a great insight into dental health for women, for overall health, how it disrupts the workforce. Because yes, now we have mental health care, but not menopause care. Can you imagine menopause days? I say all this because it was interesting that after the documentary, so many people approached you and the other providers in the office and said, I'm a survivor of breast cancer. I've been told I can't take hormones, right? And so I felt like crap for the past maybe 10 years. And it wasn't until you and Jordan and Heather, the other providers, leaned in and said, that's not accurate. That picture is not true. Right. What we have to do, though, is understand you, understand your body, get more information, individualized care for you, because yes, your body still needs something. We can't say, great, you got through chemotherapy, you're a survivor, but now you still have to fill in the state, which doesn't feel good. So I love that what we do here is that what you've said to summarize it is that it's getting down to not a one size fits all. We understand all the things around it. Let's put this in the picture and let's figure out how you can live your best life.
Right.
So here's my follow-up question. This is kind of like in the hot seat question, right?
Yeah. Okay.
So we know over, for many years, we've been told that estrogen in particular is bad, right? Is bad, and just recently the black box warning came off of estrogen. What damage, in your opinion, have we done to women by putting fear into using hormones? How have we affected because you said bone health, brain health, heart health. What does this mean for those women who've lived in this fear kind of period? And what does it mean for ongoing health?
My answer to that is what have we done as a result of that is, to be concise, we have ruined lives. and we have lost considerable productivity for what is ultimately half of our population who move into those years, and are just the emotional distress of not being supported and it not being understood. But it has perpetuated something that's just incorrect. It was flat out wrong to begin with. It should have been known. We can do a whole separate episode about this idea of evidence-based medicine. And while that sounds positive, can lead you down this road where the WHI was evidence-based medicine, but it led to an entire generation of providers and females, and ultimately their loved ones, to suffer the consequences of having somebody that they didn't get to live their life to the fullest, that did not get support of their health span, and as a result are going to lose productivity through the rest of their life. And I don't think that that's hyperbolic to say. I think I'm being very nice when I put it that way.
Are.
Yes,
you are. I knew it at the hot seat. I was like, ooh, I'm gonna it's like a softball over home plate in the middle to see how far you crush this.
Yeah.
I didn't know exactly how hard you'd crush it, because I know personally how you feel about this, because it is, even as you're talking and having this conversation, as a woman at 47, it gets me emotional, right? It gets me mad, and I don't think when you look at correlations, I shared with you earlier, I went to the dentist this morning and to get a cleaning. And after he finished, and I didn't have any cavities, thank goodness. I probably would have gone back, but I asked him, I said, hey, what correlations are you seeing with women, perimenopause, menopause, right? There's hormonal shifts. Are you seeing with dental health?
And
he said, oh, hormones. You mean when they're pregnant? And it's so ironic that you said earlier on, when we're out of our childbearing years, we're kind of forgotten about, right? You're not having kids. Move on. Next, right?
Yeah.
And it was interesting to me because I said, no. I said perimenopause, menopause. And I said, I referenced the M factor. And if you remember that, the dentist on there said it's such a huge correlation because of bone health, mouth health, teeth falling out. And you have women who are in that chair who are saying, I've done all the right things for all these years. Why is this messing up? And he said, I've never thought about that. I've never thought about that correlation only in those childbearing years. How does that make your blood feel? Is it boiling right now?
It is.
Where's your head going, Brandon?
Ultimately, if you look at, and this is not to demonize dental professionals.
No, he's a lovely dentist.
Right.
But it also says about education needed.
Right. Yes, and this is a problem because you should be very educated on this topic. Yeah. It affects half of your population, or potentially more, depending on what the demographics of your population of patients that you see. It's critically important, and I'll tie that back into cardiovascular health now.
Yeah.
So yes, when you lose this hormonal support, or these changes occur, and there's also gene transcription changes, epigenetic changes that occur to this loss, and this loss of signal and support that is seen with hormones. Separate topic, right? We can do an entire episode on epigenetics and genetic expression. There is bone loss that happens. Teeth are bones, right? They are attached to bone. They also are a living part of our body that have a blood supply, nerve, various things. How many people, this is where everybody gasps in the M Factor movies, is how many females lose a tooth so many years after the induction of perimenopause or menopause. That's very impactful. Specifically for cardiovascular health, oral health plays a major role in heart health or just cardiovascular disease. So that also includes strokes, peripheral vascular disease, and a myriad of other problems. There is clear research that shows not only does your oral microbiome play a role in nitric oxide support, which helps your blood vessels, there is also a direct correlation, I'm going to blow some minds for a second, behind using antiseptic mouthwash and hypertension. And it's not a good correlation, meaning that they have taken young volunteers and had them use antiseptic mouthwash, and they consistently had higher blood pressure than the non-user cohort. Wild, right? Just a simple, I'm going to change my microbiome with antiseptic mouthwash, affecting hypertension mechanics. Then there's the whole idea that our oral microbiome and these organisms that live there and should be there, by the way, we should support them. They are necessary. For nitric oxide support and production, we require these organisms just like we require them in our gut. So we shouldn't fight them and kill them. We should support them and support the appropriate kinds.
Yeah.
What ends up happening when you have periodontal disease, so that's gum disease, is that there's multiple mechanisms of bad contribution to cardiovascular health. There is actual seeding of those organisms into the plaque formations. That's often a causative, it's been supposed as a causative mechanism for plaque formation for many, because consistently we see nitrosative stress, peroxidation of lipids, and these bacterial organisms from mouth origin present in plaque formations. So chicken or egg, who knows? But you know it's not positively contributing to that plaque, meaning it's not going in there to eat those plaque formations.
Right.
It's only contributing to the inflammatory burden. In addition to that, like I said, the nitric oxide, and we can spend a long time talking about how important nitric oxide is. But nitric oxide is the thing that helps with our blood pressure, helps with cardiovascular support, and is also one of the very first signal mechanisms, meaning when you lose nitric oxide production capabilities in your body, that is the initiation of a degenerative response. Meaning that if you look at when does a plaque form? At what point is that first tip? Yeah. And nitric oxide is right towards the beginning. There's actually a layer sort of right before that, and other things too. But that ability to form a plaque or injury to a vessel wall starts with things called advanced glycation end products, or the glycocalyx. Then there is disruption of nitric oxide or nitric oxide production, which changes blood flow dynamics through that. It also promotes an inflammatory response that causes cell adhesion to occur. Platelets start to aggregate. Other inflammatory mediators start to aggregate. These little things called macrophages come in and they start getting activated and saying, what can I chew up and how can I mess with stuff? And then lipids get accumulated. And then as a result, then you start forming foam cells, increasing particle sizes inside the wall. Boom, you've got a plaque. That's that progression. But it starts with metabolic burden, this idea of oxidative stress or a dysfunction in your metabolism. That's not just transient, right? That just happens. If you go you're living great, but you have a cheat day, that's okay. We got to test your body every now and then. The Rock does it, and he looks awesome.
True.
But true. Nobody will deny that. But the idea is that you're largely behaving appropriately with your physiology and you're minding it, basically, meaning you're being mindful of it. And you're trying your best to control it in these ways that are manipulatable, but also not just getting, like I mentioned, people are going to be like, holy crap, I got to throw my Listerine out. Well, okay, that's a separate problem. Yes. Well, what am I going to do? My mouth is going to be foul, right? Because that's what helps. Well, maybe we have to balance your microbiome orally, and your mouth won't be foul. That's ultimately, you can use all the Listerine in the world. And if you have an altered microbiome, you're going to have halitosis still.
Yeah.
You're just going to kill it periodically. And as a result, you're going to cause yourself to have hypertension and cardiovascular disease too. Nobody wants to have stinky breath and heart disease.
No.
That is not a
You
do not put that on your Tinder profile because it will not get you grabbed. That's for sure. No.
No one's swiping for that.
No, absolutely not.
No. Gosh, you've done so much you've decoded a lot for us today. And, as I look through kind of our questions, when we started this, right, I was like, here are some 4 big things that we're going to talk about. But we've really been all over the place, right? So I'm going to ask you kind of dealer's choice. Okay. What is kind of the one thing you want people to hear? Because we have started about heart health. We talked about cholesterol. We've talked about lab values, which I think is so insightful because I think that people think it's the thing that I do. Check. If it's good, move on, right? You've been insightful even about hormones, right? Because we've talked about how we've created fear on that. And it's about educating yourself and being around a provider who's also educating themselves for the latest and greatest information. And now we're all throwing out our mouthwash and looking at our dental health in all different ways.
Yes.
So as we go on with Decoded, right, we are going to take these topics because we could be here for days, right? We could be here for days talking about.
You know I can talk. So.
Yes, we can. I do. So with all that, what would you say is the bow that's on this present that you want people to walk away with thinking about differently than when they started this podcast? How are they different now than when they started listening to you? And what's that reason why?
Sure. I love that question. So that's going to take us back to the very beginning. Mm-hmm. We're talking about it's not just about LDL and that number. To look at what are the true risk factors? What are the true modifiable risk factors for cardiovascular disease? And those are things that it's not, like if you look at LDL cholesterol and that number and control of that number, it's very small. The impact is tiny by managing that. And very often, the management of that number and the sole management of it vis-a-vis certain drugs are going to cause more harm than they're worth, ultimately. And that's true for many. Not true for all, but for many. So modifiable, like you can't change your family history. You know, like maybe you should have picked better parents. I don't know. Like that's a joke, right? We don't get to do that. But the modifiable things you can do something about are your blood pressure and intelligent ways to affect your blood pressure. I talked about one that seems like off the wall, but it's real and has good science behind it. But there's many, many others. But also things like obesity, that's impactful. But I will tell you the number one thing that is impactful, that is a modifiable risk factor for cardiovascular disease, that should be important to everybody, is this idea of insulin sensitivity. Yeah. Insulin resistance, therefore after that, and then type 2 diabetes. That's a modifiable factor. I didn't say that it was easy, but it is modifiable. And learning how to have a better relationship to insulin and glucose modulation in your body, right? And we'll do an entire episode on insulin resistance because those mechanics are very important. Metabolic dysfunction is, or there's a different term in cardiovascular disease risk modifications and markers called metabolic vulnerability. And this idea is how vulnerable are you to metabolic disturbances or perturbations in your biochemical makeup, essentially. And how does it predispose you to everything else? But that insulin sensitivity model, that insulin resistance and type 2 diabetes, is more predictive of cardiovascular disease than even smoking. Yeah. We all know smoking is bad. There is basically not much that is good about smoking. But to think of type 2 diabetes as something that is more harmful, more costly to you from a cardiovascular disease perspective should be impactful, right? Because it'd be like, you know, smokers are very few and far between. We both grew up in a world where we smoked inside, right? Like that.
We didn't smoke inside.
Well, we didn't, but you know, right. this occurred. Like, you go to the restaurant, it's friends, like there was the whole like smoking versus non-smoking. Like, does it matter?
Right. And they were smoking in the car, and they didn't like roll their windows out this much.
You get the ashes on you.
You're on the floor.
Yes.
Breathe. Yeah.
It's changed. We know it's bad. Is the point, right? But there is not enough information. There is not enough evidence towards focus on that idea, even for patients who are type 2 diabetics. And that also makes me very mad that we have this very glucose-centric model of glucose management and insulin sensitivity versus paying attention to insulin, which is the signaling mechanism. So many of the patients that we see have insulin disruption, insulin regulation problems. They come to us because they want to lose weight. Well, insulin's job is to say, you need to store stuff. If that insulin's allowed to be high all the time, you're constantly getting the signal of store these things. You can do a calorie reduction diet. You can be eating 1,000 calories a day. Your body's going to hear, I need to store this, as opposed to running your brain, running your heart, and building muscles. So we have to change those mechanics. You have to view it from that direction. And then as a result, weight management will occur. But we're also making you healthier at the same time. We're protecting your heart. We're protecting your brain. So that would be my long-winded answer to that question, is to pay attention to true, modifiable, very impactful risk factors, and not just something simple like LDL cholesterol. There's other markers, ApoB. It's an important independent risk factor for cardiovascular disease, but it's not the end-all be-all. It's not even close to as impactful as managing type 2 diabetes. Lp(a). You're going to hear everybody talking about Lp(a) because guess what? There are some really cool drugs going to come out on the market that are in phase 3 trials right now that are going to be blockbuster drugs that directly lower Lp(a). So as a result of that, everybody and their brother is going to be talking about lipoprotein(a). And while it is impactful, it's also not the end-all be-all. It requires the larger picture, the understanding of the nuance and the pattern that is in front of you, and not just, oh, take this drug to lower that marker and you'll be fine. It's going to be the new LDL cholesterol. That's just it. It's a new form of that. And now you'll take both of these things, and I'm sure in 30 years we'll start to understand that they had consequences too.
Yeah. Ever evolving, ever growing, ever learning. Yeah. So one thing people may not know about you, maybe they do, I don't know, is that your brain thinks in movie quotes, song lyrics.
Yeah.
So if you could summarize this episode with one movie quote,
oh my gosh,
one song lyric, what would it be?
I don't know. I mean, I would have to think about that. I wish I had, thought about that before, and then I would have come up with something good.
Something like Talladega Nights.
Well, now I'm going to be like mad if I don't pick just the right one.
What do you mean? Like something about Ricky Bobby? Like what would Ricky Bobby say about this?
I don't know what to do with my hands.
I don't know what to do with my hands, right? Thank you. So if you don't know what to do with your lab results,
yes.
This is Decoded. This has been episode 2. We've had a lot of great information. We've talked about hormones. We've talked about labs. We've talked about how to talk to your provider, how to decide if you need a different provider, because you should be having this education. It shouldn't be confusing. It shouldn't be overwhelming, right? It should be insightful. It should make you think, how do I live my best life, right? Because we have one life. Might as well make it fun, right? We might as well make it the best. And we're glad that you joined us today. So stay tuned. Follow us, like us, share us. If you're seeing this on social media, drop a comment about what you liked or other questions that you have. Brandon will be able to answer those in the comments. Or if you have a topic for a next episode, let us know. We're here for you as we decode. Thank you, Brandon.
Thank you.
And make sure that Tinder profile doesn't include bad breath. Thank you. Until next time.